A 43-year-old male who has a history of chronic myeloid leukemia, which was diagnosed 6 years back, came to our OPD with a complaint of sudden onset defective vision of 4 days duration. He was on treatment with tab Imatinib 400 mg daily once since his diagnosis. He had no history of any other comorbidities and no history of any other drug intake. He also had a history of slight pain on eye movements. On examination, his right eye was absolutely normal, but in the left eye, the vision was 1 meter counting fingers. The color vision was defective and the pupil showed an RAPD. On fundus examination, we could see that there was disc edema in the left eye, and the field showed a depression, and the macula was normal. And we did a VEP, and that showed a delayed potential of P100 in the left eye. An MRI was done, and there was intraorbital enhancement of intraorbital portion of the left optic nerve was swollen with increased signal intensity and contrast enhancement, but there was no other evidence of demyelination or tumor infiltration or cerebral venous sinus thrombosis. So we came to a provisional diagnosis of left optic neuritis, and the tab Imatinib was stopped for this patient, and he was started on injection methylprednisolone 500 mg IV BD. And within 1 week, his vision became 6 and the disc edema completely resolved. So he was converted to oral steroids and tab Imatinib and discharged, and tab Imatinib was restarted after 1 month. But soon after restarting Imatinib, within 7 days, the patient's vision again dropped to 612 and the disc edema reappeared. So this time we again admitted the patient. Tab Imatinib was stopped, but we decided to skip IV methylpred, and the patient was kept under observation. And in 10 days, the disc edema completely resolved and the vision became 6/6, but the field effect persisted. So the final diagnosis we reached is Imatinib-induced optic neuropathy, which was of late onset. And Imatinib, as we know, is a selective inhibitor of BCR-ABL tyrosine kinase, which is used in the treatment of chronic myelogenous leukemia, acute lymphoblastic leukemia, GIST, etc. And a wide spectrum of ocular side effects are reported, but usually they occur within the first 3 to 6 months of starting Imatinib. And a lot of side effects, especially fluid retention symptom like periorbital edema and papilledema, retinal hemorrhage can occur, which are more unlikely. The retinal glaucoma, papilledema are more unlikely in this case. And from our case, we can find that Imatinib-induced optic neuropathy can occur at any time after initiation of treatment with this drug, and it can be either passive edema due to fluid retention in the connective tissue or extracellular matrix and inhibition of platelet-derived growth factor receptor, or it can be due to optic neuritis. And different mechanisms may be at play simultaneously, as in our case, where the initial episode was undoubtedly optic neuritis, as evidenced by the VEP, MRI, and the visual field changes, and mandated treatment with steroids along with cessation of Imatinib. But the second episode could have been a passive edema, as the disc edema resolved just by stopping Imatinib. So whatever be the reason, the first step in the management of a patient on Imatinib presenting with vision drop is withholding of the drug. But it is important to rule out other intracranial cause of optic disc edema like demyelination, leukemic infiltration of the CNS, cortical venous sinus thrombosis, etc. in a patient with CML before Imatinib-induced optic neuropathy is diagnosed. These are my references. Thank you.
Nice presentation. And Imatinib, you said induced optic neuropathy is because of inflammation then. What is the reason behind? I mean,
it can be, ma'am. Optic neuritis is reported, and optic neuritis, the reason it is a side effect that is very rarely reported with Imatinib, or disc edema can occur also due to fluid retention, which can occur with treatment of Imatinib. Generalized fluid retention can occur, and even optic nerve disc edema, fluid retention can cause this disc edema.
And it affected one eye, not both eyes?
In this case, only one eye. In literature, both eyes has been reported.
What is the percentage Imatinib affected?
Very less, ma'am. Very less. Only.
What was the cause of your patient actually? I just came now, so I just wanted to know what was the why the patient was on Imatinib.
He had CML, ma'am. Chronic myelogenous leukemia.
Okay, so can other things be also a cause? Just thinking that can the drug be one of the effect? Can you think of any other things which can be also affecting it?
Ma'am,
because did you just because that is also one of the side effects of a drug, but usually we don't take it. Some other things we are focusing on initially. So what are those things will come to your mind first than thinking of
Imatinib?
Yes.
Yes. Initially we thought it was just another idiopathic episode of optic neuritis. unrelated to the drug. And we treated as another, just a case of optic neuritis, the leukemic infiltration of the
That
optic
is what
nerve.
I am
Yes,
saying.
yes.
Can it also be a,
Yes.
like how long was the patient under treatment? Can it be a infiltrative type?
Yeah.
So did you think about in those terms?
Yes, ma'am.
And then when you stop it, because you have to follow up these patients. So once you are stopping this drug, yes, drug effect you are saying. So maybe you are seeing an improvement. But these are very dicey things. They are under longer follow-up. So are they going to change on the drug or regimen, or because if again it recurs back, your disc edema, so what are you going to give your opinion to your oncologist, how they will be dealing with it and all?
We thought of tumor infiltration initially
Yes.
as a part.
So
we took
you
an
must have done some protocol, some test for those things.
Yes, we did an
Yes.
MRI. The patient was on remission. At that moment, the patient was on remission. But tab imatinib is a lifetime drug. It has to be continued.
Yes.
And the patient has been on the drug for 6 years. There was no, the blood picture was normal at that time. And we did an MRI. We looked for any feature of tumor infiltration of the optic nerve or in the CNS, anywhere. But nothing was there. Just there
Okay.
was enhancement of the optic nerve.
Sometimes patients are there long term. You see some lymphoma patients and all are there, and long term treatment also they are there, and under treatment also there is a recurrence of this optic edema, disc edema, which is there, and it is usually unilateral things.
Yes.
So sometimes you have to be also taking those into consideration, thinking that if the vision is dropping, then you have to be very careful in giving also some intravitreal things, which also goes in the long run.
Okay,
So
ma'am.
this is something there.
Okay.
So this drug is a effect, you had it, but can it be a infiltrative thing? Should be always a differential.
Always, yes, ma'am.
Okay.